Bismillah ar-Rahman ar-Rahim. This is Haidar Yahya, the marketing manager of Asino in Iraq. First, I would like to welcome all of you and thank you for attending our webinar. Then I would like to thank the Department of Obstetric and Gynecology in College of Medicine, University of Babylon, as well as our distinguished speaker, Professor Rahim Haloub and Professor Ali Naqash. The moderator of this webinar is the well-known Professor Bushra Al-Rubai, head of Babylon Center for Postgraduate Obstetric and Gynecology Studies, consultant in Babylon Maternity and Pediatric Teaching Hospital. Professor Bushra, the floor is yours.
Okay, thanks a lot. Good evening. Welcome everybody. It is a good day to share with you knowledge and talk about a public crisis to try to lessen its morbidity and mortality and for our patients. And before we start our meeting, we express great greeting and thanks from Chancellor of University of Babylon and Gynae Department and Dean of College of Medicine for Prof. Rahim Haloub and Prof. Ali Naqash and Asino Company for their efforts to share with us this meeting. And before we start, the talk will be for the Dean of College, Prof. Safa Sahib, in this meeting. Prof.
Thank you very much.
It is yours.
Thank you. Assalamu alaikum. Good evening, everybody. As a Dean of Babylon University College of Medicine, it's an honor to meet you in this new interesting medical crisis, which is all involved all of the world. And I welcome to all students, stagiaires, and professors from various medical colleges in different fellowships countries. And it's a pleasure to say welcome to all of you, my dears. I hope you get from what we're going to learn and illustrate about the healthcare system in our country, and hope we respond to COVID-19 pandemic, and hope you enjoy our session and brief information to put our knowledge together to maintain and develop a better healthcare system could be offered ever for helping our people, especially those with the pregnant women exposed to the COVID-19 crisis, and get information to helping our people and to get a perfect health and get rid of this virus, as well as help each other, know each other, and evolve the humanity-based healthcare provider pyramids. Thank you to all of you for attendance and participation. Hope you enjoy this opportunity with Babylon College of Medicine, Babylon University, waiting for your fruitful feedback and God willing. Thank you very much, and welcome again to all the attendants and professors and the lecturer. And thank you for the Asino for their great efforts in making this webinar. Thank you very much.
Thanks a lot, Prof. Safa, for your talk. And we start our meeting by we miss our frontline medical workers fighting COVID-19 and being passed by this disease by Al-Fatiha مع الصلاة على النبي محمد. Start we talk. Our talk will be on management of COVID-19 by Prof. Rahim Haloub, consultant of Gynae and Obstetric, Basildon University Hospital, UK, clinical teacher, University College of London, RCOG Overseas Investigator and Examiner, ex-chairman of RCOG ILG. Now the floor for you, Prof. Rahim.
Thank you very much, Dr. Bushra. Very kind of you for your nice introduction, and thank you very much for your invitation to give this lecture, and thank you for everyone actually attending the lecture. I think with regard to our knowledge now with COVID, it's actually progressing. When we talk about COVID at the beginning of maybe in March or April, it's different from what we are going to talk about it today, because our knowledge changing very rapidly, and there are a lot of building up of our knowledge during the past five months. And if you look at we look at the ancient Babylonian and Ashurian, how they dealt with the treatment of pandemic, and at that time, a plague, a major pandemic at that time. They actually adopted the ancient approach, which is prayer and maybe herbal medicine and all that kind of thing. But at the same time, they adopted a modern approach. And the modern approach is the lockdown. And due to the fact that they did not actually know the origin of the problem of the pandemic, why? And we actually did not actually know the origin of the pandemic apart from knowing that it's coronavirus. But no treatment, no approach, nothing. And we adopted what they'd adopted before, lockdown. But again, the additional thing we've been doing is actually debriefing. Debriefing, we do it weekly. It's a collection of data which is actually generated by our local, not a national, but local, in addition to a national approach. So in every hospital, we have a debriefing. And the debriefing meant to call everyone to communicate with the others with their input into the treatment of the COVID-19. And that is why we are actually building a knowledge day by day. And that's very important. Again, our fathers during Babylonian and Ashurian adopted the same thing. They asked the doctor to actually go to the market and collect information about the pandemic. And by collecting information from different patients, they are building their knowledge. So we are actually adopting the same thing. In addition to that, if you look at the maternal mortality report in the UK, you can identify the viral problem with leading to maternal mortality, which is actually the fifth in the maternal mortality etiology, according to the maternal mortality report. And these viruses identified already like a flu virus, which is coronavirus, and we added to it COVID-19. But the difference between the corona and the flu virus actually coming down very rapidly from 2010 due to the introduction of the vaccination for pregnant women. Now, the mortality from the flu is very, very minimal. And therefore, if you look at what happened now, and I just identified the WHO report about UK, Iraq, and global, and you can actually look at the case in the UK. It's about more than a third of the million, with a mortality about 41 more than 41,000. And the figure between the brackets actually is the London mortality and London cases. Why London? Because London is a very highly concentrated area, 14 million living in one area. And it's very important to look at that and reflect that to Baghdad and the big town in Iraq. And that's why you find that there are a lot of things reported from the big cities and Baghdad. And even in Baghdad, you have a lot of patients from the north of the river comparing to the Karkh area. in case of the reporting cases and the death, number of deaths and number of patients admitted to the hospital. But if you look at the population of each country, like Iraq, according to the WHO, the population about 40 million. In the UK, the population about 70 million. But if you look at the total case, we have actually, proportional to our population in Iraq, we have actually a lot of COVID cases more than the UK. But of course, the mortality less than the UK. The good thing about Iraq is they are reporting recovery, and the recovery rate in Iraq is about 157, nearly 158,000. And in the UK, we don't actually report recovery, number of recovery. I don't know why. We are the only country which did not actually report recovery cases. Globally, we are about 9 million inhabitants on the earth. And until now, we have about 24 million infected, and the death is about nearly approaching 1 million. But again, the recovery now is very good. The recovery rate about very high comparing to the number of the cases reported. If you compare that one with the Spanish flu in 1918, we had about 80 million dead from the Spanish flu. In India, only about 18 million. The current global case, we have a lot of reduction now in the cases. The current one is in the region of 7 million, but the majority of the cases are mild, 99, and severe, only 1. While before we have about 5% severe ones. Just to give you an idea about that, there is a group, international group of coronavirus study group, identifying these cases which should publish 40% mild with no hypoxia, and 40 moderate with not a very bad pneumonia, maybe mild pneumonia, and 15% when you have very severe pneumonia with hypoxia and all that kind of thing, and 5% critical and life-threatening. The problem here is we have acute problem and we have a long-term problem. We have to identify corona is not actually finished when you recover from it. You might actually have problem, long-lasting problem. And the immediate problem, you are very familiar with it. And while the long-term problem, neurological problem, psychological problem, encephalopathy, depression, anxiety, and problem with sleep and all that kind of thing, even movement might be affected for a long period of time, and you need long time to recover from it. We identify the problem with the pregnant woman. We put it in the category of high risk group. A pregnant lady due to immunological changes, physiological changes during the pregnancy, which might actually augment the infection from a mild to a very bad infection. And not only that, but up to about 20% of the cases during the pregnancy might be in the region of either severe or critical because of the physiological change. In addition to that, there is another thing during the pregnancy, whether the baby affected or not, and how the baby affected. Until now, we're talking about vertical transmission. We don't actually have any validation with regard to that. We don't have any confirmation that there is a vertical infection. There are reports. However, if you look at the report carefully, probably the baby might be infected at the time of delivery or intrapartum, at the time of delivery or immediately after delivery. And I'll come to that in a minute later on in my talk. Now, with regard to the complication in the baby and in the mother, if you look at the maternal mortality, of course, we have a higher maternal mortality in COVID. And if you look at, in particular case fatality, it's about 1.2, and that's actually very high comparing to the normal situation with the control group. And the number of patients require admission due to lung problems, about 10%. And with regard to the baby infected, the people actually felt that it might be infected from the mother before delivery, but in fact, a lot of people proved that that was wrong. Baby infected at the time of delivery, because they found that the baby infected or positive within 12 hours of delivery. With regard to the miscarriage rate, there's no effect of the COVID direct effect. I'm talking about maybe indirect effect, but direct effect to lead to miscarriage rate being high. But in COVID, there's no increase in the miscarriage rate. But there are increase in the stillbirth, and 4 times with COVID about 11.5 per 1,000 deliveries, comparing to 4.1 per 1,000. Prematurity very high. Prematurity during during third trimester is very high, or higher than normal. And of course, neonatal infection. We need to know more about these items in order to plan the antenatal management and intrapartum management for the baby and the mother, and therefore future might actually telling us might be a different findings. In the US, they are totally different. The number of admission different, and hospital admission among pregnant women about 31.5, so it's higher than the UK. Comparing to non-pregnant pregnant with COVID, about 5.8%, so it's about nearly about more than 5 times. Now, what about our management? Our management really is very important to look at the cornerstone of the management. Number one, to protect ourselves, doctors, nurses, paramedics, support worker, porter, and all personnel helping with the treatment and management of the COVID patient. And then that's a very important one. Then the safety for the patient will come, and of course, to protect the community. Very important to protect ourselves, then the patient, treat the patient, because without us, the patient cannot be treated properly, and without treating the patient properly, we cannot protect our community. What's the ideal plan? Ideal plan on the labor ward, we have to identify the patient with maybe query COVID or maybe definite COVID, and admitted to an area with a negative pressure if available, or isolated patient area on the labor ward, and that's very important. And of course, with regard to the ITU, majority of our ITU actually are COVID, and therefore a lot of ITU is mainly COVID. We are not allowed any other patient to be admitted to that area, and we call it a red area. And I will come to that red area and like traffic light allocation of the hospital area now adopted in the UK. In addition to that, people adopted a hospital for COVID only. There's no other patient admitted, like the Nightingale Hospital in London, and another one in the Midland, and another one in the North. That is only for COVID, and only complicated COVID, not an ordinary COVID. With a lot of requirement for patient to be admitted or to be transferred to that hospital. Not everyone will be admitted to it. Protection, of course, you are very familiar with our protection, with the headgear and mask, which is a specific one, gloves, and all that kind of thing should be adopted in order to protect the personnel. And therefore, we have a different type of approach, which is supportive management, which is very important, general management of COVID-19, target management for pregnant women, and of course, for pregnant women, the approach will be multidisciplinary, general and obstetric. Now, limiting the disease is very important. Before we're talking about how we deal with COVID patients in hospital, we have to limit by lockdown, which is that one which is adopted by our ancient Babylonian and Ashurian, when they actually employ lockdown, meaning that they keep the patient in the area, their area, or their home, in order to prevent spread of the problem to other people around them. In addition to that, protecting people who are vulnerable, like the pregnant women, like people over 70, and people with comorbidity, hypertension, diabetes, and all that kind of thing. Now, the message, they tell you that, well, look, you have to stay at home initially, but later on they downgrade that one. And of course, here the comic here saying that we threaten people that if you don't, you will be intubated by a gynecologist. Now, with regard to the admission to the ITU, ITU admission for pregnant women is higher than non-pregnant women, and of course the requirement for ventilation more in a pregnant woman. Mortality, they are the same, pregnant and non-pregnant. And the age of during a pregnancy, you can actually tell that younger age group, pregnant women between the age of 15 and 24, do very well comparing to women at the age category of 35 to 45. With regard to the ethnicity, the white have an advantage over non-white. The non-white have about twice more than the white to be affected by COVID and to have bad outcome. Blood group O less likely to be affected by COVID or less likely to have complication comparing to other group like group A. Now, how we actually deal with the pregnant woman, remember that the problem is the gravid uterus, and therefore we adopted lateral tilt. Lateral tilt for like if you have a problem with the cardiac problem. Now we don't actually adopt lateral tilt, but mechanical uterine tilt, meaning that with two hands, you actually shift the uterus to the left side of the abdomen to relieve the inferior vena cava and aortic compression. Some people ask me about termination. When do we actually terminate? We are not talking about termination in early, but we are talking about any pregnant level. And therefore, we have to put like a general policy. If there's a pregnant woman with no improvement in the saturation, then like the cardiac patient, you have to deliver the baby. If there's no improvement in the general condition during the treatment, you have to deliver the baby, or maybe deterioration in the general condition of the patient, sudden deterioration, you have to deliver in order to improve the ventilation. Or if there is an obstetric indication or medical indication, you have to deliver. Now, before, if you ask me when I delivered the first lecture to the Iraqi colleague, we actually say that you intubate early. Now, you should not intubate early. You try to avoid intubation at the beginning because the etiology of the COVID changing now. But we have to put a criteria. When do we intubate? If you have a failure of first line of breathing management, and the breathing management now in the ITU, they adopted face down, which is prone position, which is very important. And they actually give oxygen through the catheter, nasal catheter, with a very, very high flow, very high flow. And remember that very high flow, you have to protect yourself from that flow because you could actually acquire the virus from the patient. And one of our colleagues, Anita, tell me that sometimes we might reach 50 liters per minute. And you can deliver also by face mask, but there's one thing which is very important. That should be non-rebreather mask, meaning that with the patient don't actually breathe what exhale, so it will be a fresh oxygen going down. And majority of the patient managed by CPAP while they are face down. Of course, when you have a pregnant woman with gravid uterus, very difficult to achieve that, and therefore we introduce the lateral tilt. And the other indication for intubation, when there is a dramatic reduction in the saturation, or maybe sudden drop in the saturation, or maybe a very difficult case like the pregnant woman, we have to go for intubation. But in general term, they don't in favor intubation. And a practical approach with regard to management of the patient on the labor ward, of course, we have to admit her to an area, and we have to allocate midwife with not sharing any management with other patients, meaning that midwife one-to-one care. And that means the midwife will be in charge of the patient, is not moving away from that area. And of course, with regard to the approach of management, it should be multidisciplinary, which is a combination of maternal medicine, obstetrician, and of course the anesthetist, virology, microbiology. All these people will come together in order to plan according to a guideline of critical care outreach. Now, in general term, we have to avoid abdominal delivery if we can, but if it's urgent to deliver patient to improve the ventilation, then we can do it. But try to avoid a patient abdominal delivery by under GA. Try to probably put an epidural in labor, even before thinking about the time of delivery, in order to avoid general. And if no epidural, or you cannot install epidural, spinal to deliver, which is the common thing we do in the UK. There is a general support if you have a patient with COVID, but not very bad, mild, moderate, then supportive things like paracetamol, fluid intake, multivitamin, healthy eating, and encourage more green vegetable and fruit. The major issue with COVID is actually hypoxia, and it's a marker for bad condition, meaning that the more the patient more require oxygen, the more unwell is the patient. And of course, the young patient compensate very well, and therefore they can cope with hypoxia. I was talking to one of the anesthetists a few days ago, and he told me that he witnessed a patient in the ICU talking on the telephone to the family with the O2 saturation about 80, 85. Remember that the cutoff for intervention is 90, and therefore this actually patient coping very well with hypoxia, and we don't know why actually. But you have to watch for, from that level, you have to watch for sudden deterioration. And therefore, you have to look at the oxygen like a drug rather than just like oxygen. And therefore, you have to understand how much oxygen you deliver when you actually put a mask on the patient. And you have to put a target. Your target should be about 94, 98% saturation. And of course, the flow of the oxygen will change very quickly, rapidly, and you can shift from one method to another method as required by the patient saturation. In addition to the fluid, and there is antibiotic. Before we are thinking about other antibiotics, but now the question about giving cephalosporin rather than other antibiotics, because cephalosporin, especially this type of ceftriaxone, is very effective in management of pneumonia, and therefore this is actually now recommended. It's 1 to 2 grams per day intravenously. Antiviral for a pregnant woman, only 2% of pregnant women had the antiviral in the UK, and they are actually in the recovery study. They are not routine antiviral. So routinely, we don't actually give antiviral to pregnant women, but only 2% of them because they enroll in the in the study. Now, the major shift of our management is really steroid, and we will come to that later on, because the steroid is very helpful with regard to recovery and shorten the recovery time. and avoiding cytokine storm. Chloroquine now, nobody actually talk about it apart from Trump, but that we'll leave it. And with regard to the steroid, there are two types of steroid called methylprednisolone. We recommend that for pregnant women, and we give 30 to 40 milligrams daily, and the dexamethasone for other patients. And sometimes if you have a problem with the giving the oral medication, you can give IV hydrocortisone 80 milligrams twice daily intravenously. The dexamethasone and the prednisolone can be, of course, given orally by tablet or by suspension or maybe IV, and the dosage very well known with the oral 2 tablets of 3 milligrams, 3 tablets of 2 milligrams once daily for 10 days, or intravenously about 5.9 milligrams once daily. And the prednisolone, which should be methylprednisolone, about 30 to 40 milligrams daily. That will be given for 10 days, and occasionally we might actually extend it to a longer period of time, depending on the recovery of the patient. But beware that the blood sugar should be managed very well and should be monitored in non-diabetic patient and diabetic patient. But with the diabetic patient, of course, gestational diabetes in the UK is very high. A lot of patients with gestational diabetes, and therefore you have to watch the blood sugar very carefully by checking before and after meals and regularly 2 hourly. And of course, if the patient already on steroid before for health problem, then you have to change the type of steroid. Patient with negative COVID or maybe query, still you can actually treat her with steroid, no harm at all. There is one group, the international group. You can report anything you feel that reportable. You can report that to international group www.covid-pregnant-ch. Anyone can report to them. Now, with regard to the abdominal intervention, you have to be very careful with the introduction of the GA, and when the patient requires GA, not a spinal or epidural, every member of the team should be out of the theater, apart from the anesthetist and the ODA. The ODA will be helping the anesthetist until the tube in and everything set, and then you are allowed to enter theater after about 20 minutes. Of course, you are wearing everything outside theater, and when you finish, you have to drop everything in theater. You are not allowed to take them out. Diathermy, if you use diathermy, it should be having or attached to the diathermy suction in order to get the evaporation from the after coagulation directly into the suction without being inhaled by any person in theater. Now we have a local protocol in our hospital with regard to the management of COVID, especially when it comes to the VTE. Of course, the anticoagulation now is one of important treatment due to the fact that we know now the etiology of COVID and the effect of COVID on the lung is not actually inflammatory, but it's due to microvascular thrombosis, and therefore we have to adopt giving the prophylactic dose of anticoagulation, but be careful with regard to measurement of platelet count, because remember that if the platelet count below 30 and the patient deteriorated, you cannot give her a therapeutic dose. And you have to be very careful with the bleeding. and therefore you have to measure the platelet count. And if the patient on prophylaxis, you should continue if the platelet less than 50, but when you drop to 30, you have to stop that completely. Now, how do we calculate? Of course, calculate the anticoagulation depending on the dimer and depending on the creatinine clearance and depending on the body weight. And there's a difference between the prophylactic and the therapeutic. Remember that you are shifting from therapeutic, from prophylactic to therapeutic when there's a major deterioration or if you think that your patient becoming critical. Remember that with regard to if the anticoagulation contraindicated or platelet count less than 30, you have to adopt the mechanical thromboprophylaxis, and that's actually electronic one, in order to make sure that you are going to avoid DVT, which might lead to maybe additional problem with the pulmonary embolism. Now, shifting from oral, some people might actually come on already on oral anticoagulation, like apixaban or indoxaban, and you have to change it to low molecular weight heparin. And the low molecular weight heparin is actually much better than the oral in case of the microemboli formation. And of course, the measurement of the renal function is very important, because impaired renal function will then call for changing the therapeutic measurement of anticoagulation, and you are more likely to give unfractionated heparin rather than ordinary heparin or oral treatment. With regard to people talking about vitamin D, vitamin C, and zinc, we know that with regard to vitamin D, we have to give a double dose of about, or maybe more than double, in the region of 30 to 40 microgram. Unlike ordinary non-COVID pregnant woman, we give 10 microgram. Vitamin C we give up to about 1,000, and zinc about 25 milligram daily. And there are actually studies indicated that the recovery of the patient will be shortened when treated with the vitamin D, especially. With regard to neonate, of course, we know that there is no vertical transmission, but we have a number of cases confirmed COVID positive, but there's no evidence that the virus can be carried in the breast milk, and therefore we advise the women to continue breastfeeding, but taking precaution of gloves and washing and mask during breastfeeding, and try to avoid touching face and all that kind of thing, precaution in order to prevent transmission to the neonate. When we escalate any patient to the ITU team will take over, and of course, when there are indications to give early intubation, then we will do it early. But remember that they are very reluctant to intubate if they can, and they rely very heavily on nasal tube and giving high oxygen instead of intubation. And of course, the CPAP is very important here, because you are giving a small amount of oxygen through a high pressure in order to open up the alveoli. Now, we are people talking about the antiviral, and one of the antiviral talking about and available in America, and I'm sure available in Iraq, and people rely very heavily on it, although there are many failures with it. It's very well known now. This antiviral you can actually give 200 milligrams intravenously over about 30 to 120 minutes, and daily you continue with 100 milligram intravenously. And if the patient require mechanical ventilation, of course, that might change. And it will be treated for about 10 days or maybe shorter than that, depending on the recovery. And if the recovery delayed, you can extend it to about 14 days. But of course, it's very expensive. Each dose of 200 milligram, I think, costs about in the region of $2,500. What about the Russian vaccine? Russian vaccine is not available, and they told me about 2-3 days ago, they told me that in Iraq it's available for $150. But until now, it's registered, definitely, but not approved, because they cover the stage 1 and 2, but they are still in stage 3, meaning that the volunteers are not completed. And according to the Russian report, they will be completing the stage 3 by maybe November, December, in order to make the vaccine available to everyone, not only just the daughter of Putin, but everyone. Daughter of Putin will actually enroll in the trial, but not as a patient, routine patient. You require 2 injections, 3 weeks apart, and they are it is killed virus. And remember one thing, that attenuated vaccine is not indicated in pregnant women. Now, we have one thing which is very important to mention before I finish: mental health, well-being, looking after yourself. Very important to work as a team, avoid social media, because there's a lot of rubbish actually in the media. Take a break, of course, every now and then. Eat well, healthily, keep communicating with family, friends, and colleagues. Talk about difficult cases, because that will help other people to cope with the pressure. And of course, sleep well and engage in some activity in order to take your mind away from your work. In our hospital, I mentioned before also that the airline, like British Air and other airlines, they actually open area in each hospital, and they provide like coffee, food, and to the staff. You can go there and relax, and like they treat you like you are in the airplane. And this is very important help. And other hotels in the UK, they open their doors to accommodate doctors and nurses overnight if they cannot go home, or if they are tired, they can actually go there and relax for a night or afternoon, because that will actually help a lot to improve the morale and increase the morale. Outcome of when we talk about outcome, we talk about the fatality in the UK, about 12.6 of the total, and comparing to Italy, it's about 12%, nearly the same like the Britain. And with regard to the fatality in China, reported to be 5%. Now, traffic light, I mentioned earlier, traffic light, we adopted that traffic light areas. In our hospital, there are 3 areas now. The green, where any patient can actually come to the green area. And in between, there is a yellow one, and the red one is the COVID one. And you cannot go, as a doctor, you cannot go without taking a lot of precaution, change your clothes, putting all gears, like going to theater. And you are not, it's locked. You are not allowed to go unless you communicate by either telephone or knock on the door. And of course, future reduction of a new virus. Remember that the coronavirus available in animal, and there are thousands of them available. And people try to change the interaction between animal and human. And of course, we have people looking at the safety and biodiversity, monitoring the movement of animals from one country to another country and within the country. And therefore, until we have the development of virus, we can then control it that way. Thank you very much for your listening.
Thanks a lot, Prof. Rahim, for your nice lecture.
Thank you very much.
And we will keep the questions to the end.
Thank you. Thank you very much.
Now the talk will be for Prof. Ali Al-Naqash. He's consultant of gynae and obstetrician, Croydon Hospital, University Hospital in UK. Dr. Ali, the floor for you.
Thank you, Dr. Abusha. Thank you very much. Hi, everybody. Nice to be with you again. It's about COVID and the pregnancy, the talk. And this is just introduction to the subject, you know. Just also some brief things I noticed over the last few months, and I wanted to just to share it with you. Next slide, Haida. So coronavirus, our novel coronavirus, which is the other name is SARS-CoV-2, is a new strain of coronavirus causing COVID-19. So the corona means it's a big family. It's not a one virus, it's thousands of them. And we all remember what happened in Wuhan city in China last year in November, and nobody knows till now how this thing happened. So many theories, conspiracy theories, some people who think it was a kind of done deliberately, or some people think it's part of this war between China and the United States. However, the truth is not out yet. Really, nobody knows, because we are still in the middle of the crisis. Next, Haidar, please. So that's how it looks. It's like a Quran mean Taj. That's the way it looks. And these spikes are very important, because this is where the attachment happened to the cells. And don't forget, this is an RNA virus. So essentially, the mission of the virus to get in, integrate into the nucleus, and then use the nucleus to regenerate. So the virus on its own cannot survive. It needs our cells in order to be able to reproduce and then survive. Next, Haidar, please. So how the world doing right now? There are countries in Europe which few months ago they were in the peak of things. However, things are improving. For example, I'm talking about the UK because we live in the UK. In March time, I remember in our hospital, we had like 10 to 15 deaths a night. And that's a lot. But even in the middle of the crisis in UK, the number of pregnancy affected by COVID was not great, tell you the truth. And I don't remember anybody died from pregnancy with COVID in our hospital. And when I went and investigated what about the rest of the hospital in the UK, there are no reported deaths in pregnancy from COVID, as far as I know just now in UK. The position in the UK now is much better. We reach our peak, we plateaued, and now we are descending. And now our preparation is for the second wave, presumed second wave of corona infection. If you look at the rest of the world, for example, people who reach the plateau like South Korea, Singapore, Hong Kong, even Iran now is in a better situation than us, because number of the cases in Iran now at around 1,500 a day, 1,500, much less than what it is in Iraq right now. There is a second wave now in France and Germany. How Italy, there was a talk about second wave, but I don't think it's as serious as the first wave. Living in the West tell you something. In the West, always they take their precautions early, and they prepare the population for that. I tell you about the population in the UK. Now, whenever you go out, if you go to any supermarket, you can't see anybody there without a mask. Yes. So there is some kind of a precaution among the population that they have to protect themselves. Because they've been told that when the winter happens, there's going to be a second wave. Next slide, please. So this is how you look at Iraq, how it happened. Back in June, number of the cases were much less, number of the fatality obviously recovered, but then gradually things start building up. And you can see July, the cases were increasing. I remember it was like 2,000, 1,500 a day, and then it gradually become 3,000, and now we're coming to the area of maybe 4,000 a day. So, and still people think for Iraq, the peak is not reached. That's at least what WHO said just recently. But the good thing, if you look at the blue is the number of people cured from the condition. This kind of statistic, you hear it a lot in Iraq. Every day, this amount of people cured from the condition. In UK, they don't give you such statistics. I don't know why, because they think there is no way of 100% sure to be 100% sure that somebody is cured from the virus. There are so many theories, and some people think that even people who had an infection can get reinfected again. And there was a few reports from Hong Kong about that. I just read it, in fact, just a while ago. A man in Hong Kong reinfected with coronavirus. Next slide, please. Okay, the next slide. So early on in UK, they are very organized people. So very early days, they had a guidelines about the management of coronavirus in pregnancy. That's from our college. And this is freely available for everybody. Any one of you can download this document, and in order for them just to see about how the West managed coronavirus. When everybody was excited about the chloroquine, the British in UK, they didn't take that really at all, and they had to do their own study. And they did their own study about the chloroquine, and they discovered the chloroquine, as Rahim said, is not useful and sometimes can cause increased morbidity. Next slide, please. Okay, so, and then we come to the very popular question. Is being pregnant predispose you or make you vulnerable to coronavirus? And the answer is not, to start with, because that's the message we had. Pregnancy don't appear to make you more unwell than others. However, we all know that pregnancy, it has a kind of a state of immunosuppression because of the higher steroid levels. And also, even in UK, they consider pregnant women among the high-risk group. But what do you tell to the patient? You're not going to make her panic and tell her like you are more susceptible to corona than others. You shouldn't do that. And next slide, please. However, the most recent report from the MMWR study, which is Morbidity and Mortality Weekly Report from the Americans, suggests that indeed pregnant women who are infected are more likely to be hospitalized, and they are more likely to be admitted to the ICU. That from the American experience. And the risk of death, however, is similar for both a group. But much remains unknown. The thing about coronavirus, COVID-19 infection, things are evolving. We're hearing many different bits of news each day. And what is a kind of solid fact in March and April now is become not that solid, and people start to doubt it. And then we're talking about the vaccine, and is it really going to help? If the vaccine going to help, why should infected people get reinfected again? Because that's supposedly these people, they have the real infection, they have the high amount of antibodies than any vaccine possible. So is really vaccine going to make the difference? This is still an open question. Next slide, please, Haida. So COVID in a pregnancy, however, is associated, as Rahim said it, with maternal morbidity and preterm birth. However, there is no evidence that it can lead to increased miscarriage. And there was a French study, and this is when the French was at the peak of the problem. They done this study and they found that 24% of women receive oxygen support, with 43% require invasive mechanical ventilation among the group of women they were studied at the time. And that, don't remember, the French had their peak, and that was a few months ago. And that was probably in May time or something. And since then, things have changed a lot because there is more accumulated knowledge and experience from other countries. Next slide, please. So among pregnant women who give birth in the States, you see the American, they have very kind of accurate kind of statistic. They like numbers and all that. And then you can just see how many pregnant ladies infected with COVID in 2020. I couldn't get such a number from the UK. So, but the American got it. They have statistics about COVID in a pregnancy, and they have this number published, which is 6,600 cases. And among them, half of them, believe me, half of them were severe, and 681 mean nearly, how much you can say 10% were critical cases. And they had mortality in America. There was 52 cases of coronavirus mortality in United States. I know in Iraq it has happened. I've heard from friends. They had a few cases of COVID death related. But in UK, yes, I know Rahim, he mentioned some statistics about the mortality rate. But again, in all the places I know about, and my friend, nobody mentioned about a pregnant woman with COVID who has died in the UK. Next slide, please. So what about how do we protect? What do we tell the women? I think this bit of information now is like a common knowledge. Every little kid know about it. You have to wash your hand. You have to keep the spaces. You have to avoid touching your face, nose. And when you sneeze or you cough, you have to bend your elbow. So nobody now shake hands. If you want to greet anybody, you have to shake his elbow. And today, however, on purpose, I have shaken hand with somebody. I didn't feel guilty after that, but you shouldn't do that. Next slide, please. So what about the fetus? Yeah, Rahim, he said all that. The vertical transmission can probably happen, but they're not sure. But till now, the evidence said is unlikely to happen. There are 2 reported cases published of IgM found in the serum of newborn babies. So they think this is most likely to be representing a human immunity response of the baby rather than the virus being transmitted through the placenta. However, there are definite reports from China saying that there was no evidence of that happening. But again, do remember that China information is outdated because all goes back to December time and January time. And many countries now probably have much more and better experience with COVID than the Chinese themselves. Next slide, please. So what about the baby? What's going to happen to the baby? It seems like good news for the baby, because this is a study mentioned in the Lancet saying that infected women with COVID-19, they couldn't find the virus neither on the swab of the baby or amniotic fluid or the cord blood or the breast milk. So women with COVID-19 can breastfeed their baby. So the advice is she can breastfeed her baby. Yeah? So next slide, please. So that's again the same message, because if you're going to make the woman scared of breastfeeding, her baby might die from that rather than from COVID-19. Next slide, please. So what about the symptoms? The symptoms is, that's a problem, is it? Yeah, because everybody says most of the time it's asymptomatic. So what about the diagnosis of it? When do you think you have the condition? And this kind of slide, yeah, can give you a clue. I think the most important thing is the fever, is the temperature. And then when I mentioned that to my sister, she works in a COVID ward in UK. And she said to me, Ali, most of the cases she knew about, they didn't have a temperature. So that's real life. And this is what they tell you. They tell you temperature is very common. Again, if the temperature is happen for anybody, they're going to have the aches like all of us. They're going to feel the fatigue. What about the cough? And they say usually is dry. Can happen, but usually is dry. Do they have sneezing or no? Sneezing is uncommon. Sore throat is uncommon. So sometimes they do have gastrointestinal symptoms like diarrhea. But one important symptoms we heard about is the loss of sense of smell. And some people, and again, sense of taste. That's very important. And that was mentioned a few weeks ago. So for you to remember, if you have a flu-like symptoms, you assume yourself to have COVID-19 until proven otherwise. This is the most practical kind of assumption in these days, because you have flu symptoms, you assume that you have COVID until proven otherwise. How do you prove otherwise? By testing yourself. I think the difference between us living in the Middle East and people living in Europe or in the developed countries is the ability to get tested quickly, swiftly, and cheaply. That's the difference really, because the rest of the management is kind of similar and is not a high-tech management. Next slide, please. So we come again to the, is it corona, is it not? So we come again to the same kind of classification. Temperature is common. If you look at the common things, there are not many. There are two common things, the cough and the temperature, and the rest are not. So temperature, I said to you, reality said different things, because my sister, and I believe her, all the cases she had, they didn't have temperature. So how do they always talk about it being common? I don't know about your experience. You might have some experience about that, but that's real life. But you should take it like the most important two symptoms are the temperature and the cough and loss of sense of smell or something. Next slide, please. So what about the test? How you get tested? Obviously, probably you know about it. One of the tests which is talked about a lot to start with, which take long time, called the PCR. What is PCR? It's simply you culturing the virus. So if you culture a virus, that's probably the most accurate way of identifying the infection. So you do swabs, you culture it, you find it, and it has to be there itself. However, I remember just like 6 weeks ago, 8 weeks ago, there was a lady booked for elective section, and she done, all ladies here before elective section, they test them for COVID-19 nowadays. So this lady was tested, and they found the PCR to be positive. However, when I talked to Philip, the anesthetist, he said to me, Ali, don't worry. This lady had the COVID 3 months ago, and she was treated. And I said to him, why she is still having the virus in her swabs then? He said to me, this is remnant of the virus, it's not the real infection. So how much you believe in that, I don't know. There are so many people who already had the virus weeks ago, a month ago, but they still carry remnant of the RNA in their throat. So do they still be called COVID positive? That's the thing. But we treated her as positive, and I have to wear the gear, do all that, and do all the masking and all that. And by the way, the mask we use here in UK, you get tested first. So they book you for a special test to the mask to see whether this mask is going to be effective for you. And if the design of your face doesn't doesn't go well with the usual mask, then they have to provide you with special type of mask, which looks like those used for chemical warfare, because you cannot use the ordinary mask. The ordinary mask is not going to be effective in your case. That's before I forgot, because I thought I mentioned that to you. Here, all the doctors get tested for mask. They call it a mask test before they get accepted to use the usual mask. So what about the other test? The other test, which is the much swifter and less also popular, I don't know, for some reason, less popular among people, is the antibody test. They say it's a very good test, very swift test, it only take minutes. And what you essentially, you take in a drop of blood and put it on a kit, which looks like a pregnancy test kit. I don't know whether it's freely available in Iraq or not, but there are countries which give this freely. And I'm going to show you some example of that. So next slide, please. So the three tests available, we have the PCR, which is essentially we're looking for the RNA of the virus done through swabbing of the nasopharynx and the nose. And we have the antigen test, and we have the antibody test. The most accurate test is the PCR, because essentially you are culturing the virus. However, the exception, if this lady had the virus long time ago, she was cured, and there is remnant as well of this virus in her throat, so the test would be also positive. So it's not 100%. It's not 100%. So the other test, which is called the protein, they look for a specific protein unique to the coronavirus, and they are found on the surface of the virus, which are on these spikes. This is not widely available, but this, they say, is very good screening tool. But I guess this is the kind of test is going to be available in the next few months after the PCR going to be probably the old generation, because PCR takes time, and time is very important most of the case for people who are going for operation and everything. Some people cannot wait for 3 days just for a test. And then we come to the antibody test, which I talked about. It's going to check two things. The IgG, which indicate immunity or past infection, and the IgM, which indicate acute infection. And this kind of test is the one which is speedy test, which can get a result in a few minutes. And the Korean, they say you can get it in 4 minutes. I don't think you use the test widely in Iraq. However, here in UK, they sell it in the pharmacies. If you go to any pharmacy, you want to buy it. I don't think it's cheap though. But for all health people working in the NHS and the health carers and all that, they give to them this test freely if they want to. My sister, she's a GP. She got tested twice, and every time she meets a patient with a COVID-19, she gets very anxious, and then she go for this test again, and she gets tested third time. And there is no limit on how many times you can get tested really for COVID-19 here, if you're worried, if you're among working in the high-risk places. Next slide, please. So going back to the accuracy, because people also always doubt how accurate this antibody test, the IgG and IgM. IgM, like for all other tests, indicate acute infection. So it all depends on the days after the onset of the symptoms. One study, or many studies found, if it is within 14 days window, the accuracy rate can be 70%. And this accuracy rate can increase to 90% within 35 days windows. However, what happened after the 35 days, nobody knows till now. And the thing is about this virus infection, it's not like polio virus or other viruses in which you develop an immunity and it stays with you for life, or even the measles. These antibodies are not going to last for a very long time. And that's why people can get reinfected. And that was I think, in my opinion, one of the major hazards of this virus. It's the immunity is not last long. It doesn't last long. So that's why I put a question mark on how important these vaccines going to be. Next slide, please. So this is how it looks, the antibody test. It's like a pregnancy test. You put a drop of blood in that corner, and then you wait for a few minutes, and then you can get the line. Is it the line either in the IgG, and that means it's a previous infection, you got immunity, or in the IgM, mean acute infection, or you don't have any line, which would indicate that you don't have infection. So this kit, some people say you can buy it for 50 pounds or $50. Some people say in some country $15. But I will show you example. Some countries do it freely. Another slide, please. So this is, you look at that, this is what happened in Israel right now. People get screened. There are these small cabins on the road. They can have the swabs and look at the man, and this all done free of charge. And this is how they screen their population. So anyone can go there, get tested, and free of charge. And this is in a country who is, I think, considered now among the developed countries, whether we agree with that or not, but look at how they treat their population. Next slide, please. So if we go back to the Latin America, Brazil now is among the top countries in coronavirus. Each day there is like 60,000 cases or 50,000 cases. And why do they have this high number of cases? It's simply because they screen a lot of people. And look at that. This is on the road. She's pricking his finger and doing the antibody tests. And this is something which can, I don't know, probably this is free of charge. This is in Brazil, which is not considered to be a rich country. And so I think for Iraq, really, if they want to tackle the problem, now they are proud of screening 20,000 cases a day. They should do more than that in order to control the growth of the virus among the population. Next slide, please. So the message is for all these pregnant ladies, is stay safe. But stay safe doesn't mean stay at home and lock your doors on you, because you cannot do that. Many of pregnant women now, they go out and they see their doctors, and I've seen everybody, but believe me, all of them, they wear this mask, yes, and they stick to it. And as a doctor, if they see you in the hospital without a mask in labor ward, the patient look at you suspiciously and with some bitterness. I can see some of them, they say, why are you doing that? So you feel immediately guilty about it. So if you don't want to protect yourself, at least protect your patient. Thank you for that. And it was lovely talking to you again. I just want to remind you about one thing before we go, that right now in Kabbalah University, they started a study on COVID in pregnancy in Iraq. So there is a doctor there who, Bushra knows her, Dr. Nasser, who's doing that. She's recruiting patients from all provinces. She started with Kabbalah, now she's doing it with Basra, and I have asked her to be in touch with Bushra as well to screen her and see exactly, because what we want to know the extent of the problem in pregnant women in Iraq and what type of management they had in order to learn lessons, because that's the most important bit. Thank you.
Dr. Many thanks, Professor, for your presentation. Our last presenter will be the well-known Professor Bushra Rubai, Head of Babylon Center for Postgraduate Obstetrics and Gynecology Study, consultant in Babylon Maternity and Pediatrics Teaching Hospital. So, Professor Bushra, you may start sharing the screen.
Okay. Thanks a lot, Haider. My talk will be brief about cases in Babylon City. This is a picture for Babylon, nowadays an ancient. So we have when وين داخل الصورة وين شنو قبلها الصورة. COVID-19, it is a pandemic, constitute the largest global public health crisis in century. It is public health and socio-economic challenges. Regarding Iraq, نقدر نسوي full screen.
Yes, Victoria, you can give it full screen. Can you
Okay.
give it full screen?
Okay. Regarding Iraq, because the cases been rising from its start in February until now, rising regarding affection and death and recovery. Up to yesterday, the coronavirus cases 219,000 and the death 6,740, but the recovered 161 cases. Intensive care admission 566. This is regarding all over Iraq. The cases increased, the recovery increased, and the death also increased. What about the frontline medical workers being affected by the disease a lot, and there's a lot of death until the 13th of August. In medical workers, all of them 10,878. But as a doctor, 1,077 cases. The death in doctors, 29, while for all it is 77. So it is a key. I think we have to put a question on it. How would we change this fact? Regarding from Babylon, the total cases until 25th of August, it is 9,788 cases, and the total death in Babylon alone, it is 375. We shift to a pregnant woman with COVID-19. We have suspected cases and we have mild cases, as Prof. Rahim, he categorized them, the moderate cases and the severe cases. The severe is the most critical. The mild and moderate, and mostly it is antenatal, but the severe cases, it is the one of them, she's a doctor resident, been severe but recovered, she's antenatal 30 weeks. The other 5 cases in the severe been ended by postpartum death. The moderate cases, all of them antenatal and been recovered, all of them. We have cases that they have no symptom, but when they attend, they have exposure to the disease a few weeks before their attendance. The husband being positive and they are contact with him. One of them previous to cesarean with 14 days before, with the husband positive, and one of them previous one, both of them with no symptoms and been well, and then even after surgery they are well. The other one is prime gravida, 16 weeks, attend for cerclage and revealed to be positive and postponed the surgery. One of the nice cases that a lady, she's para 2, both cesareans, full term, been with labor pain, admitted, vitally stable, with uterine contraction, fetal heart positive and regular, admitted, preparation for emergency cesarean, spinal anesthesia failed to be performed, so the decision for general anesthesia been done for her, She has been recovered from anesthesia and been well, but oxygen saturation continued to be 85 and below as post-operative. She's all right and she's talking and mention everything is all right, but her oxygen saturation been dropping. We referred her for HDU and consultation of physician and preparation for CT. Within 1 hour, CT performed for her revealed it is she is a case of COVID. Be referred for infectious ward in Marjan Hospital and stayed there for 6 days and been well. Her baby is well also. The next case been referred from Al Mahawil Hospital as a case per one cesarean, no living, full-term with a non-case of COVID positive, although she has no symptom. Spinal anesthesia performed, a live female baby, smooth operation, and been well after the surgery. The other case, which been received as prime gravida term pregnancy, a twin, but presented, she is not a non-case, but her representation as fever and dyspnea and tired, and when CT performed, she is 70% affection of the lungs, emergency cesarean performed and under spinal anesthesia. She has been recovered, but her babies both been dead after 30 minutes and 2 hours from the surgery. Possibly because of the hypoxia she's already in before she has been admitted. Regarding the cases with fatality, and all of them are postpartum cases. 3 of them after cesarean and 2 of them after vaginal delivery. One of the cases, para 5 cesareans, been admitted fever after 10 days from her cesarean. CT revealed 80% involvement of the lungs, and she has been died after 3 days from her admission. The other one, she's a prime gravida, been elected for cesarean 8 days ago, present at that time. All of them, they have no signs and they are not cases of COVID, but deterioration after the surgery. And her death after 6 days, and the other prime gravida, all of them are young. 4 days after the cesarean, involvement of CT by 50%, and her death after 7 days. The other postpartum cases after vaginal delivery, one of them, she's multipara, para 5. At time of vaginal delivery, she has no symptom and not diagnosed. But 22 days later from the delivery, present with fever and dyspnea, and been in the infectious ward, been died after 2 days. And the other one, which is the last one as postpartum death, she's a prime gravida, vaginal delivery since 20 days, been received as fever, dyspnea, and her death at time of the arrival to the infectious ward. So all of them, although they are young, but all of them share they are postpartum, 3 of them after cesarean and 2 of them after vaginal delivery. So we want to mention that antenatal, good prognosis, postnatal, bad prognosis, and if we have knowledge to share to lessen this morbidity and mortality. And thank you a lot for your listening, and now we will open for the questions. And the question, we start by questions to Prof. Rahim. We pick some of the questions. One of our colleague mentioned that, are there late complications of COVID-19 on thyroid gland? Prof. Rahim?
You mean thyroid gland complication with COVID?
Yeah.
No, no, we don't actually have, or we did not identify a problem specifically with thyroid gland. But remember that the hypothyroidism during the pregnancy is very common anyway, and majority of the patients were not actually known probably before admission. So therefore, having like recognition of the thyroid or hypothyroidism in a patient admitted with COVID does not mean that COVID actually encouraged the development of hypothyroidism. No, definitely not. No relationship with COVID.
No relation.
No.
Okay. The next question also for Prof. Rahim about the use of inhalation xylocaine as local vasodilator to increase the oxygen saturation. What is your opinion?
In fact, people actually mentioned that. People mentioned that a few times in order to improve the vasodilatation and to improve the ventilation and to counter effect the microemboli. But again, that's not actually very common. Mentioned occasionally, but not routinely.
Other question, would you recommend giving prophylactic vitamins to pregnant?
Well, with regard to which vitamin, I mentioned the vitamin D. I mean, according to the Royal College guideline, we actually give vitamin D 10 microgram to pregnant women, non-COVID. But I mentioned the COVID patient. With the COVID patient, we actually go up to about 30 to 40 microgram in order. I mean, there are actually publications confirming that the vitamin D might actually help with the recovery of COVID patients, but definitely in a higher dose.
Okay. The other question is, does tocilizumab have a role in management in women with COVID?
Which one?
Tocilizumab. Tocilizumab. It means
what kind of
tocilizumab, which is
is that antiviral or what?
antibiotic.
Antibiotic. All right.
Yeah.
Well, antibiotic. I mentioned that initially at the beginning of a problem with COVID, people actually recommend erythromycin, but now the general approach for a patient admitted with COVID, especially ITU management, they actually go immediately and give cephalosporin, 1 to 2 grams daily.
Okay. The other question is that, is there any data about recurrent infection to be significant enough to say it is a recurrent disease?
Well, Ali mentioned a few reports from China and a few report from France, I think, that identify people who actually recovered from the initial COVID infection and they got infected again. But they are not common. They are not common.
Yeah, I just read one today. There's one in Hong Kong as well, got reinfected. And there looks a problem. Some people, they produce low level of antibodies. They get infected, they have antibodies, but they are weak antibodies, so they don't last long.
Can I come back, Ali? One thing about that, the reinfection, people actually think that there might be mutation in the virus, and therefore the initial infection with a virus which is not actually similar to the one infected now. So therefore, due to the mutation, the virus, the RNA might change a little bit, and therefore they will have mild infection.
Yeah, and that means they would become a different virus, is it?
They are different virus, indeed, very true. Yeah.
Very confusing.
The same talk, is there evidence about reinfection and it is no long term, need further research and data?
Well, long term, we don't actually have a long term. That's the problem. We have a condition with age of 5 months only, or maybe 8 months, if you take the Chinese patient from December 2019. And therefore, long term, we don't know. I mentioned long term effect of the COVID-19, like neurological problem, psychological problem, anxiety, depression, all that kind of thing is the effect of the virus. But direct effect on the lung, people actually mention about the fibrotic effect and a chronic lung problem in the future.
Okay. A question for Prof. Ali about a close contact with the baby and the mother. Does it considered as a risk?
No, I think, yeah, because any woman, in order to breastfeed,
Breastfeeding does not affect, but the close contact, this is the
you mean
question.
The close contact.
Close contact between the mother and her baby.
Yeah, have
If
you
she's
seen,
COVID positive.
Victoria, have you breastfed your babies? When you breastfeed your baby, there is no closer contact than breastfeeding.
Yeah.
تعرف المي لما تحط البريست هتحطها. What is closer than that?
That's very true, actually.
This is the question. This is the question.
Closer than that, يعني.
No. I think you take ordinary precaution, like you take precaution with other.
It is the mask. The mask should be put even she's breastfeeding her baby.
Yeah, indeed.
Common sense. You use your common sense. So ما راح تعطي البيبي مالتش قبلة من هاي الكبيرة أو تعطي مستحيل. يعني أنت you have to use your common sense. Use your mask and breastfeed your baby. On breastfeeding, the body would be warm because of your body, and the baby has to be close to you anyway.
I think that question actually came because Ali put a picture without a mask holding the baby.
The other question, I think for me, it is regarding a primary twin that lost her babies. She's a full term, but she attended late with the dyspnea, and she is life-threatening condition. That's why I think the death of both fetuses from hypoxia already before she has been arrived to us. This is the cause, not because there is something in their babies. If you have any note, Prof. Rahim, with me for this case?
Well, yeah, I agree with you, because I questioned that. Remember that when we talked before the meeting, and I mentioned to you about what happened actually. I believe that probably that because she's young, maybe younger age group, and I think young age group. Sorry. Yeah, if she is young, she was coping well with hypoxia, and probably the O2 saturation dropped even below 80, and she's functioning. And of course, the baby will be affected definitely, because if it's a very low O2 saturation.
Yeah. And other question: why morbidity more in postnatal period? This is.
I noticed that from your presentation. Nobody actually mentioned that, but remember that the intervention, you are more likely to interfere and deliver the baby urgently when you have a major deterioration, and therefore the patient is already critical, and she might have multi-organ failure already, and that multi-organ failure contributes to the fatality.
The other question is that if a lady, she come with COVID positive and she is now in her acute status, shall we prepare her right now for termination of pregnancy by cesarean section? No, if she is a term or near term, or we postpone it until being well?
No. If she is mild case, you can actually aim for vaginal delivery, and of course that might change completely if there's a deterioration or drop in saturation. You can actually change, but a mild patient can actually go admitted to labor ward and delivered vaginally, but you have to watch sudden deterioration. Very, very important.
It means that it is not an indication to perform surgery for COVID positive. This is
well, if she is mild no, of course not.
If she is positive, mild or moderate.
Yeah, indeed.
If it's severe, it might be need.
Oh, definitely. No. The problem is when you have a very bad condition, a critical patient or severe patient, your thought is about how to improve the general condition and how to improve her ventilation. And like the cardiac patient, if the patient come to you to the casualty with a cardiac arrest or pulmonary, major pulmonary embolism, what you do, even in casualty, you have to deliver the baby immediately in order to improve the ventilation. So therefore, really, for the benefit of the patient, you have to deliver the baby.
Okay. What is your opinion regarding giving heparin, low molecular heparin post-operative?
Well, no,
listen.
I think that's very important. The low molecular heparin will continue anyway after delivery, and therefore, I mean, the recommendation by the Royal College with regard to normal patient after delivery will continue for 10 days anyway. But that's a prophylactic. In a COVID patient, you have to go from prophylactic to treatment, meaning that it's not 40 or 60 milligram of glycine, but you have to go to double it in order to give therapeutic dose rather than prophylactic dose.
Okay. Another question is that does smoking have preventing mechanism against coronavirus?
Preventing? Well, I don't know about that, to be honest with you. They actually talk about alcohol. Alcohol can actually, patient will deteriorate with COVID. And I believe that maybe smoking will probably deteriorate more because it's actually affecting ventilation also.
Do we have
not protection?
Smokes in Iraq? I haven't seen any woman who smokes in Iraq. فقط أيام الكلية.
But pregnant women? No. What smoking during pregnancy is very common actually. Now we actually check for carbon. We actually routinely in our antenatal clinic we check for carbon monoxide. We have a machine. We have a machine. Every patient coming to antenatal clinic, we actually breathalyze her. We give her the machine, and she will inhale and pump through, and that will actually give her the level of her carbon monoxide. And if the level higher than 3 or 4, that means she does actually smoke, even if she denied it.
Hey, but
we do it routinely.
I've been to Iraq many times. I never seen recent Iraq any woman who smokes in front of everybody. You know.
Well, they smoke probably not in front of you.
In the private,
privately, yeah.
In private.
Other question for Prof. Rahim: is there any recommendation to test every patient for COVID before elective surgery?
Every patient admitted to the labor ward or admitted to the elective section will be checked for COVID.
That's what happened in UK. That's
in UK. That's in UK.
Whether can you afford that? That's a different problem, because tests mean money. So I guess in UK they can afford it. In Iraq, I don't think it's that easy. You know.
After delivery, for every woman, if she is not an case, can we predict if she can develop it to lessen her morbidity?
You mean develop COVID after delivery?
After delivery.
We don't know. We don't know, depending on the contact, and therefore now you have to advise patient to take a precaution, like we do, like any patient. Not only pregnant woman, but any woman should actually take a precaution in order to avoid infection. And especially pregnant woman delivered just now, you have to think about, or she had to think about herself and the baby. So therefore, precaution should be taken and continue.
Okay.
Ani, I have a question for you, moderator, Dr. Bushra.
Okay.
الكيسات مالتك. يعني in summary, how many maternal deaths you had?
we have 63 cases all, whether suspected or mild or moderate or severe. And in severe 11, 5 of them is death, all of them
5.
postpartum.
Yeah, 5. She mentioned 5 postpartum, yeah.
5 postpartum, all of them. No one antenatal.
Yeah.
Then the postpartum and death, have you analyzed each one of them? Have
Yeah.
you, what is the reason for that?
All of them, they are not in case at time of termination of pregnancy, whether by surgery or delivery. They come deteriorate post.
So they had their delivery, normal or cesarean section? Was it normal or cesarean?
2 of them normal vaginal delivery and 3 they are cesarean. 2 of them repeated cesarean and 1 primary. 2 of them primary.
وقت تسوي لهم discharge these patients? Which day they go home?
They discharge them.
Yeah, usually.
Mostly if she is uncomplicated after 1 day or 2 days.
So after 2 days after cesarean section, you send her home.
Yeah.
Okay. then the home circumstances, يعني she might have had it from the family, from them, maybe another adult living in the family who was infected, and she probably had it from the family rather than from where else, you know.
Ali, can I comment on that actually? None of the 5 discharge home anyway, Doctora. You did not, because they are critical. How do you discharge them?
No, they are at time of the surgery and the discharge. They are well. They come late with fever and they are not in a case.
But
they come late.
Doctora Aini, if they are critical.
No, they are at time of admission and surgery. They are not critical. They are not in a case.
They didn't have the condition, Rahim. They didn't have the
they
problem.
have no condition. They are as usual cases
they didn't diagnose
of cesarean.
Probably because
they are delivered and they don't have any problem at all after delivery and they went home.
Yeah, and they are at time of admission. They are not in case of COVID.
No, I'm talking about after Ali, Dr. Ali talking about after delivery, you discharge them home?
After delivery, they discharge home. They
and
have no problem.
They came back to you after how many days?
The vaginal delivery after 20 days and the other after 22 days.
All right, okay.
Vaginal delivery.
What about the critical one? You mentioned critical one. Did they actually, one of them died because of a critical?
No.
None of them.
None of them.
None of them.
They are all well, and their babies also well.
Yeah. Okay.
Well, maybe there is a possibility they had it to start with from the beginning, but because you didn't test them, you didn't discover it.
Yeah, because she has no symptom as usual. Not obligation for all of the patients should be sent for investigation and be positive or negative to know what is going on, whether mild or suspected or not. This is the cornerstone. We have to investigate all women admitted to labor ward or to operative delivery before any intervention.
But
to know,
Victoria,
to detect early.
Victoria, in order
I think
to find a solution for these postpartum death, you have to change your protocol. Make it in a way which will prevent these deaths. One of the easy changes, do the antibody test on every
Yeah. And this is my mission. I mentioned that we have to investigate women admission to the labor room or to the operative theater before any intervention. Exactly. To know positive or negative, to deal earlier to lessen mortality.
Exactly. So this is the lesson you learn.
Yeah.
Because you never know whether they were infected to start with.
We cannot guarantee.
Yeah.
And the one with the 3 with cesareans, they come with after 6 days, 8 days, and 10 days. So different times.
And you don't forget as well, the postpartum period is a very critical period.
It is a critical period.
Immunosuppressed, she hasn't retained her strength.
So it will be so clear, even she is mild, it will be complicated.
She would be so vulnerable.
Doctora, can I ask you a question about the anticoagulation?
Yeah.
Do you actually give routine anticoagulation after abdominal delivery?
Me, for all my patients, I will give it, but my colleagues, not all of them, they give it.
Okay, and if you look at the 5 patients you mentioned, did they have, I'm talking about operative, the 3 patients who had operative abdominal delivery,
No.
did they have
They
anticoagulation? They didn't.
They didn't.
Oh,
they didn't.
Okay, fine. Yeah, that's all right.
Yeah.
So, yeah. Okay, very clear. Yeah.
يعني انتوا ليش كل واحد عنده بروتوكول خاص به دكتورة؟ انتوا في one unit.
Because there is no rule to have a guideline to be on it for all.
ليش؟ There is guidelines. وزارة الصحة عندها protocol.
There is guideline, but not all obey the rules.
Adhere to it. Yeah, they don't adhere to it.
But this is lottery. يعني you're gambling with people's lives. You know, this is not right.
We did a lot of symposiums on the same, because we have maternal mortality causes of thromboembolism, and we pick it and we talked a lot about it, but still there is not all of them adhere to.
What is the argument? What is their argument? The people who refuse to do that. What's their argument?
They are frightened from bleeding or something. This is the.
They are frightened from bleeding, but they are not scared from death. Is that right?
Yeah.
Yeah, that doesn't make sense.
So the message from this meeting, we will use anticoagulation, should be routinely for all post-operative.
No, not routinely for post-operative.
For high risk, for moderate risk.
For operative delivery, Doctora, yani abdominal delivery.
Yeah.
The other thing is, to be honest with you, until now, I never seen a patient admitted with bleeding with the anticoagulation.
No, me also.
Because you are actually giving prophylaxis anyway.
Yeah, me also.
Yeah.
بهالحالة دكتورة, you have to make a protocol for the all unit, and there is no time للمزاجات هنا. ما بيها شغلة مزاجية أنا أحبه وذاك ما أحبه. This is people dying from this. People dying from this. This is a responsibility, دكتورة.
Yeah.
Whoever the head of the department, they have this responsibility to meet with all of the consultants and tell them, look, this is the guideline, this is the protocol, you have to follow it. ماكو مزاجيات بيها دكتورة, ما بيها مزاجيات. يعني احنا انت تعتقدين هاي ربما dictatorship, but this is the way they do it in the UK. This is where democracy is, and this is the way they do it. يعني احنا مو احسن منهم دكتورة, الله يخليك. لانه اذا انتم عندكم 5 postpartum death in small hospital in a small province called حلة. What about this big provinces? البصرة وغير الشكل. أنا أقول لك اليوكي كلها ما بيها maternal death واحد. يعني أنا في رأيي this is disgrace حقيقة.
Yeah.
And we shouldn't take it lightly at all.
No, at all.
You've seen the video yesterday.
That's why I present the cases, because I think there is a problem.
Now you have to think,
resolved.
Victoria, you have to think about the future. And we are learning, every day we are learning. It will be a good idea to take that opportunity and tell them that, well, look, we have a problem here and we have to adopt anticoagulation in order to prevent death. Because these patients might not actually be died because of COVID, it might be because of the thromboembolic phenomena.
Exactly. Maybe it's a PE which killed her, pulmonary embolism. That's what killed her probably.
Yeah.
It's not a COVID. Yeah, we all focusing on COVID-19, but we're forgetting the ABC, the simple basics, Victoria, the simple basics.
Yeah, but all of them, they have CT positive for COVID.
Yeah, for COVID, yeah, indeed, very true. I take your point, but the point it might be the primary cause of death.
Yeah.
Not only COVID, it might be thromboembolic phenomena rather than COVID. But anyway, we have to take it forward. We have to take it forward, and it will be a good idea for you to to take it over and then to approach people gently and convince them that, well, look, we have to employ this protocol and we have to adopt prophylaxis for about 10 days after operative vaginal delivery or after even complicated vaginal delivery.
Vagina. Yeah, you're right. This is the message for the future.
Doctora, do you know
we will
the death of
listen
COVID? Doctora,
and thank you very much, Doctora, for your information also.
Doctora, لحظة واحدة. Before you go, you have to,
thanks a lot.
you have to know that the death from COVID in Iraq is the highest in the Middle East. Do you understand that? The highest in the Middle East, the death from COVID. So you as a doctors have a responsibility toward that, you know? You shouldn't take that lightly. You shouldn't take that. And there is no place for mood and mazajat. Maybe at the end of the day, you know people how angry they are if they lose their relative. I've seen a video just today about people stopping that doctor and they beating her up in the corridor. It's very painful, very sad. Very sad. So essentially, the message is clear from this webinar. You should, in each unit, have clear, understandable, unified protocol for everybody. ماكو واحد هذا يستعمل أنا أحب هذا وذاك أنا ما أحب هذا. ما يصير دكتورة. Okay, دكتورة.
Okay. It will be for the future. I hope it will be.
No, it should
Next
be.
Next webinar will be.
Yeah, Doctora, it should be. You have the authority. You have the authority to do it. It should be like that because that's where you save the life of people.
Okay. Okay. Thanks a lot.
Thank you, Doctora.
Thank you very much. Thank you very much for everyone attending. And thank you for, of course, Haidar for his hard work and for Afino. Thank you very much.
Bye, dear. Bye.
Bye.
Thanks a lot, Prof. Rahim, Prof. Ali, and thanks a lot for Haidar for your nice cooperation and efforts. Thanks a lot for all. And we will be met next time for another webinar with another talk.
Inshallah, inshallah. Thank you very much, Doctora. Thank you.
Thanks a lot.
Until next time, see you. Stay safe. Bye-bye.
Bye.
Bye-bye.